having me here. I'm flattered, actually. The reason that I kind of got involved with brain balance and everything was as I was going through chiropractic school, I was working on a diplomate in neurology and functional neurology through the Cagan Institute. And I knew that I wanted to work with the brain and kind of doing things from a functional neurology perspective. Wow, look at that. From a functional neurology perspective, but I didn't know that I wanted to work with kids yet. And then my niece was born and some things happened. That's a whole nother story for another day. And she was diagnosed with autism. She was neurotypical, about 3.5 years old, a severe regression. She lost all of her potty training. She lost all of her words. She lost her eye contact. She went back to being an infant. And it was probably one of the most puzzling things that I had ever seen. And so it caught my eye. She lives here in Southlake. My father's a physician. He's a doctor of osteopathic medicine. He works in neurology. He works with autistic children in the autistic spectrum, and works with children that struggle with ADHD, all type of neurodevelopmental disorders. And so I chose to get involved with the Brain Balance program because I was at a seminar one time for functional neurology, and Dr. Malala walked up. And I had read his book, Disconnected Kids. I don't know if any of you have read it. It's a great read. It really outlines the philosophy and what we do at Brain Balance. We get into a lot deeper than what the book outlines because we have some sophisticated equipment and diagnostics and other things that we do that typically not available to the average Joe in your home. But there are a lot of home strategies in the book that are really helpful in kind of outlining a home program that you could implement with your child. But back on the story about Olivia, and so I wanted to figure out like what I could do to help her, because everybody that she was seeing was saying that, well, it's just something that you're just going to have to deal with for the rest of your life. And you know, there's ABA and there's this and there's some coping mechanisms, but really what you're going to have to do is to learn how to cope. And my sister, she wasn't willing to take that. And I don't think anybody else in our family was really willing to take that. And so I got to spend some time with Dr. Malala, and I got to meet his son. That kind of spurred this whole Brain Balance organization. And anyway, it was a really moving time for me, because then that's when I said, well, I think this is what I'm going to do for the rest of my life. I'm going to work with kids. And so I've opened up my first center here in Southlake, and then I'm opening up another center in Bel Air, in the Houston area, and then one in the Woodlands, because this is a really underserved population. When it comes to what people do for these kids, I'm sure, I don't know if you're parents that are struggling, maybe your child has some issues that you may or may not be dealing with. There's not a lot of options when it comes to treatment. And this is a unique treatment, being that it's multimodal and it's pretty cool. I'm not here today to pitch Brain Balance to you, but what I am here to talk about is primitive reflexes, because I wanted to give you something at the end of the day that you could do with your kids, something that you could recognize and that you could do specifically. But I do work for the Brain Balance organization, and this is a very small part of what we do. So, jumping right on in. Does anybody know what a primitive reflex is? Looks like my remote just died on. Come on, guys. You guys can talk. Primitive reflex. What does it sound like? Primitive reflex. Right? So primitive reflexes are just, let me plug this book too. So I put this PowerPoint together today, if you can't tell. But this is a great book, really good information. Reflexes, Learning and Behavior by Dr. Sally Goddard. She's visionary, she's really smart, she's a fantastic neurologist. And so I would suggest you get that book. It's really heavy in neurology. It talks a lot about pathways and things that you're not going to understand if you're not a healthcare professional. So skip that stuff. Stick to the stuff that you do know. Stick to the stuff that you can understand, because there are strategies in there to specifically address the primitive reflexes. So getting back to a reflex. Somebody, what's a reflex?
A reaction?
There we go. It's a reaction that the brain doesn't have to think about. So if I'm sitting in a chair and I smack my knee comes up, right? It's something that cortically your brain does not have to involve itself in. It happens by way of the spinal cord, goes back down to the effector muscle, and you see something happen. And so that's a reflex. So going to a primitive reflex, it's just essential for a baby's survival in the first few weeks of life. And they provide rudimentary training for many later voluntary skills. And so for me to move my arm from midline to right, that's a voluntary skill, correct? And so primitive reflexes help children come out of the birth canal. They help them feed. They help them with a CO2 reflex. They help them with things that cortically they cannot involve themselves in yet. And so primitive reflexes are really important to understand because, first of all, they need to be there. Because reflexogenically, as the brain grows and develops, other systems are built upon them. And so I want you to write, can we flip the lights on and maybe turn? I'm going to just show you a developmental pyramid. So when we approach a child developmentally, especially at Brain Balance, this is how we do it. So feel free to copy this down because this is the way that you should approach your own children. Because when I get a nonverbal child, for example, an autistic nonverbal child, this is how I approach them. There's no magic to it. I do certain systematic steps to get the desired motor output that I'm looking for. So, primitive reflexes. That's going to be the foundation of where we're coming at developmentally. The next area that we're going to come from is the sensory motor systems. Sensory motor systems are super duper important. So, if we have holes in the foundation, we start to see aberrancies in the sensory motor system. So if I have holes in my foundation, primitive reflexes are apparent. Sensory systems and motor systems cannot appropriately develop. What we do know, sensory drives motor. So if you have an aberrant sensory system, you're going to have an aberrant motor output. So do any of you have any experience with children with neurodevelopmental disorders? Biobraze? There we go. So do they move differently? The way that they move. How would you explain their movements?
Less balance.
More robotic, maybe?
Yeah, sometimes.
And so it's homolateral, what they call homolateral, right foot forward, right arm forward. So it's like that versus a cross-crawl pattern where you see the right arm coming forward, left leg coming forward. So you see some homolateral movements. You can't really explain it sometimes if you don't really have the vocabulary to maybe to say what you're seeing, but they move differently. But that's because their sensory systems are off a little bit. Well, from the sensory system, from the sensory motor system, we start to build our cognitive systems. And the cognitive system is really important because that makes us us. We have these two chunks of gray matter, also known as frontal lobes. That's what makes us different than chimpanzees. We share 99% of the same DNA, yet we act really differently. That's because those two big chunks of gray matter on the front of the brain. So, after the sensory motor systems develop, your cognitive systems start to develop. And so that's to be able to think. Then you see a child sitting on the carpet, and rather than just randomly playing with things, they start piecing things together. They might start putting things in color-coordinated patterns, or they might start to be imaginative, and all that stuff comes from the cognitive system. And then after the cognitive system starts to develop, we develop the system of instruction. So then we can start to see and follow direction. So you can get a really complex type of instruction to the child, and they can go do it. So, yeah, Johnny, I need you to go get the apple juice out of the fridge, pour yourself a glass, and then I need you to take out the garbage. And they do it. And that's because all of these systems have started to develop. So when I approach a child that comes to me and the mom says, you know what, they're just a little different. I can't really put my finger on it. And I'm not really concerned about the diagnosis, because the diagnosis puts you in a category that then a physician can bill for. You met one kid with autism, you met one kid with autism, in my experience. That they can share the same label, but the very things that they struggle with are entirely different. And so this is how you approach a child. Oftentimes, conventional medicine, therapists, everyone else tries to some other different array of trying to approach a child? Well, really, if we go back and meet a child where they are versus where we think they should be, this is the direction that we're coming. So first I'm going to evaluate their primitive reflexes. After I evaluate them, there's a remediation for every one that we find. So I'm not just going to say, yes, your child has this primitive reflex. I'm going to say, yes, your child has this primitive reflex, and this is what I'm going to do to fix it. Next, we have sensory motor systems. In my center, this is where I work. I work in the sensory motor room. It's a really big room, and we do things like auditory processing, visual processing, vestibular work, balance and coordination, rhythm and timing, core strength and stability, all kinds of stuff. We do all that. And I love it because I get to be really active with the kids. We joke around. I'm on the floor. I get to play all day. And so I really love this. Also at Brain Balance, we have a cognitive room. And that's where I have two special education teachers licensed in the state of Texas, where they work in that room, and we put together a specific academic plan based upon the child's academic weaknesses. And that's where we attack that. And then instruction. This is the big thing. That's when the parents start to see these changes, massive changes in these kids. I'm not really working on the instruction because all that stuff inherently is going to happen after these systems come online. So that's the developmental pyramid. This is how I approach a child, and I've seen it work. It works really good. Does everybody have this that cares to have it? Questions? Please? Okay. So, if a primitive reflex remains active beyond 6 to 12 months, it's something that we call aberrant or abnormal. And with that, we can pretty much ascertain if there's a weakness or an immaturity in the central nervous system. So with weakness or immaturity in the central nervous system, a child can continue to develop physically, but then you still have a child they might be 12 or 13 years old, but they act like an 8-year-old. And so I often act like a 12-year-old. So I probably have some primitive reflexes. You guys are a tough crowd. So in that book, here are some specific primitive reflexes. There's many more than this, but these are the ones that I thought that we could probably work on the most. So anybody, I'm going to start pointing at people and get a little interactive here. Anybody know of any of these? You should know. Moms maybe should know too.
Rooting.
Rooting reflex. Describe for me that one.
When they're hungry, they open their mouth and kind of root around.
Perfect. Yeah. Exactly. So what happens, there's a stimulus, side of the cheek, they turn to that side, and they can feed and suckle. It's a survival mechanism so that cortically, they don't have to think about it. So that they can reflexogenically provide themselves with the nourishment that they need to continue to survive. Okay, so we're going to go through these. So the moral reflex, palmar reflex, asymmetric tonic neck reflex, rooting reflex, spinal galant. I don't know if any of you are suffering, and when I say any of you suffering from ADHD, if you have a child that has ADHD, you are suffering from it as well. Because those kids will not sit still. Spinal galant, right there. In every single child that I've ever assessed that had a formal diagnosis of ADHD, it comes from a reliable physician, not trying to push medication. This spinal galant, I mean, big glaring thing. That's something that we work on, and then these fidgety ants in the pants type of behavior starts to go away because reflexogenically it's no longer happening. And so a reflex, you can't fake it. You can't fake the funk when it comes to a reflex. And so because the cortex is not involved, reflexogenically it's just happening. It's just happening. It's just happening. You can't stop it. Next one is the tonic labyrinthine reflex, symmetrical tonic neck reflex. And these are the ones that I included today because I'm sure you're already falling asleep, and if I were to do more, you'd be slobbering. So, Moro reflex long-term consequences. So when I say response, it's really a long-term consequence. So if I assess your child has the moral reflex, then these are things that we see a concomitance of. We see these happening all the time. So a poorly developed CO2 reflex. Let me explain what CO2 reflex is. That reflex is to help perfuse the brain with blood. specifically in the brainstem, a certain part of the brainstem. Now, you could imagine that if you don't have good circulation in your brain and you're not delivering the appropriate nutrients, oxygen, and the chemically mediated things happening in your brain, then your brain's not going to function as well. You compound that with poor nutrition. You compound that with the wrong stimulation. Then you have a child that really is a mess. We also see vestibular-related problems. These are kids that can't keep eye fixation with angular head movement. And so these are your ADHD kids that are sitting in class, and every time they move their head, their eyes have to follow. Their eyes have to follow. And how really disturbing that can be is every time you move your head, your eyes move. And so visually, you have something to process every time that happens. And it can become exhausting. And so then you have kids that are now defiant. They don't want to participate in anything. And so now they get an isolated lunch because that's the fix, right? They're physically timid. They're ocular motor and visual perception issues. So the way that their eyes and the way that they see things isn't really an accurate experience of what just happened. And so they have pupillary reaction to light. Light is a painful response. So I step in the light and I have to squint. I step out of the light and it's not a painful response. Now my pupils can appropriately respond to light. So that's something else that you have to take into account. How are their pupils reacting? Because if a child really doesn't want to participate in school, and we're seeing our healthcare provider, and we never evaluate the way that the pupils react, well, how about we do that so that we can understand, is this a painful response to this child? Is light affecting them different than your neurotypical child? And then there are strategies that you can do to help that child. White paper sitting on a contrasting background, for example, on a desk like that can be a really bad strategy because that light reflecting back into their eyes is painful. Homework goes away. Don't want to do it. They don't know why they don't want to do it. They just know that it's subconsciously a painful experience. Also, lowered immunity, reactive hypoglycemia. So these are things that we see as a long-term result of retaining a moral reflex.
Cagan?
Absolutely, go ahead.
When it comes to auditory confusion, are you, what are you saying about that? I mean, like when they hear sounds?
So there's listening comprehension and there's auditory processing. So listening comprehension is to be able to hear what you heard, but then to comprehend it. And then there's something entirely different like auditory processing. I'll take dichotic listening, for example. So both ears, we hear something, so there's a noisy room. Everybody's talking, you and I are trying to talk. I'm getting bombarded with all of the background noise, but at the same time I'm trying to listen to you. That's a dichotic listening skill. And so you can become confused from an auditory perspective so that you don't hear any of it. It's all just noise to you. And so they can't really understand what they should be focusing on from an auditory perspective. And so they're not, either they're not understanding what you're saying or they're not hearing you. Does that make sense?
Yeah. It doesn't have anything to do with, because my 8-year-old has pretty much all of this. Mm-hmm. And the reason why the auditory confusion caught me is because he is loud. Mm-hmm. And I don't know if that has anything to do with, he's got so much going on in his head or something that he thinks that if, I drown it out with my voice or something, that it's going to, make things better for him. It'll kind of focus him in one way or another. Mm-hmm. Because, everything else on there, it seems,
Does he startle really easy?
Yeah. He's been on medication for a year or two now, so it's, a lot of this stuff is kind of
dampened down a little bit?
Yeah. But the other day, we missed his pills. And it was all back to this again. Yeah. But actually, in all reality, his physical timidity, he was a lot more willing to wrestle with me without the medication than he was when he was on it. Mm-hmm. So the auditory confusion really caught my.
Mm-hmm. And so when I evaluate a child from an auditory perspective, there's a lot of different things that I have to do to be able to make sure that they hear different frequencies and that the eardrum is intact, the muscles are intact. All of the things that requires an appropriate auditory response to be processed. I have to evaluate all of that, And then if it's just a matter of a processing issue, then that's something that we work on. The brain is just like a muscle. It's just like a muscle. It's plastic. It's proven now that you can change the brain. And that through different types of listening exercises and dichotic listening exercises, that you can dampen down that auditory confusion. And so we all, well, I shouldn't say always, but most of the time, children with an auditory processing disorder typically have a moral reflex. That's aberrant. It's still there.
Yeah.
That startle reflex.
With the lowered immunity, is that tied to pandas in any way then?
It could be. It could be. But then it's just having to look at the ASO titer and your DNAs, and to see if you have both of those titer levels that are high, then the strep infection's been there probably a little bit longer than 6 months. Now, if you have just one of them that's high, so let's say your ASO titer is elevated and then your DNA ACE is not really there, then it's indicative of a strep infection that's gone systemic for about 3 months. And then the treatment for both of those is going to be a little bit different. And I don't like to always be pushing drugs at things, but that's something that, I mean, you need to address that with the appropriate antibiotic therapy, refluorinate the gut, and then you have to tip the immune system back in a direction to where the chronic strep is not always aggravating the immune system. So, but yes, it can. It certainly can be a factor.
Right.
Cagan?
Yes, ma'am.
Sorry. I'll ask a question. Have they ever linked any of this to, I'm just thinking of my dad, and it seems like he's starting to develop a lot of this stuff. I wonder if your brain gets old, if you can...
Yep, because so I'm just going to draw this little picture. I'm not an artist at all. Here's the brain stem. Here's the brain, right? Goes like this. So here, right or left and right. So a reflex brain, you have the brain stem, and it comes down to the spinal cord. You have your cauda equina coming down like that. So a reflex happens here, right? So all of these reflexes that we're talking about reside deep within the brain stem, okay? Now when I say cortical, that means the outside of the brain, your cerebral cortex. That's your smart college matter, the stuff you paid for. So whenever we inhibit these reflexes, the cortex has to inhibit in this direction. So it's inhibitory and not excitatory. As the brain gets old, we have less cortical function, right? Memory becomes less of an issue, becomes more of an issue. Yeah, all the little things that you see old people starting to do. Well, that's because they're starting to lose some of this cortex, and you get less inhibition to the brainstem. And so these primitive reflexes, alive and well in old people, absolutely. Now, whenever you're coming out of anesthetic, I'm sure a lot of us have had surgeries before. When you're coming out of anesthetic, the first thing the anesthesiologist does is to start evaluating the surge tech. They start to evaluate those primitive reflexes, because that's how they know as the anesthetic starts to wear off, the cortex is coming back online, and these primitive reflexes start to die down again. And so I've got to spend a lot of time in operating rooms and post-surgical rooms and things like that. And to see that, it's amazing to see a 30-year-old guy, you do the rooting reflex on him, and he's trying to, he's still out, and he's trying to feed. And you're like, oh my gosh. I thought you would have lost that a long time ago. And so, yeah, it's something, this isn't just a holistic way of looking at the mind. This is, documented stuff. So, anyway. But yes, primitive reflexes in old people, you betcha. And I bet you there are lots of primitive reflexes in this room right now, if I had to imagine. So, moving on, because we have quite a bit more. I don't even know what time it is. Palmar reflex. Long-term responses from a Palmar reflex. This is pretty much easy to ascertain from that. A lack of a pincer grip. Now, when it comes to writing, just the basic skill of writing, if you retain the Palmar reflex, every time that my pinky approximates my palm and I stimulate my palm, oops, sorry about that, stimulates my palm, what's going to happen? I'm going to clamp down on the pencil. So these kids typically have horrible handwriting. They splay their fingers out flat on the desk. They do everything they can to avoid the pinky, the ring finger, the middle finger touching the palm, because reflexogenically, what's going to happen? They're going to do that. They hold the pencil really awkward. You get kids that hold the pencil between their fingers like this. And so that's something that you need to evaluate whenever you're looking at your own child. Look and see how they hold their pencil. If it's awkward, then you can start to look at the, I see this over here. I see, you probably have the palmar reflex, yeah? So, and it's not a big deal.
All over it. We still love you, Steve.
Speech difficulties. Now there's a big coordination. I am going to get into it. As you develop in utero, the first sensory information that you start to receive is right here. And what it starts to do is develop a withdrawal reflex. And so what happens as you're bumping around in mommy's womb, you're going to bump and you're going to hit your face, and that starts to develop this reflexogenic, you start to withdraw from things. And then that consequently develops the sensory around your mouth, and then that goes to your hands. Because we have a huge concentration of nerve fibers around our mouth and in our hands. Well, what needs to happen from that, because they develop together, we need to get independence of one another. And so, via the hand-mouth relationship, this is a big thing. You know the kids that move their mouth when they write? And so when they're writing, tongue's all over the place, tongue can come out, the jaw goes to one side. Anytime they move their head in a complicated pattern, that mouth is really moving kind of all over the place. Well, this is what we see, that they've retained the palmar reflex. Really easy to remediate, but it's just kind of something to start to take a look at. Asymmetric tonic neck reflex. This balance may be affected as a result of head movement to either side. Remember we talked about that robot walk? So kind of like this, that's that homolateral movement pattern. And they have poor ocular pursuit movements. So here, you can flip those lights for me real quick. So I'm going to explain pursuits and saccades really quick. So this is a function of reading. We read left to right. We're not Chinese. So we start here, and this is a slow eye movement going this way, but then I have to get back here to read the next line. So this is called a pursuit. And then this is a fast phase of the eyes called a saccade. So now we have this asymmetric tonic neck reflex that we're talking about. Now we've retained it. Now we're getting to the age where we need to start reading, right? And so what we have to master first when it comes to reading phonetics. Phonetics is the building blocks of reading and pseudo-word decoding. And so we have to master that skill first. It just so happens that it just requires this much of a pursuit. So with your outside cortical function, it doesn't take very much to do that. Now we're starting to progress. Now we're going into second grade. Now we're reading a little bit more difficult stuff. Now all of a sudden our kiddos starting to fall behind the cracks a little bit, because when it comes to reading, they can't read. They're still at kindergarten level. That's because poor ocular movement, and they never develop the pursuit. So if you never develop a pursuit, I can guarantee you're never going to develop a saccade. All of these things come from different places in the brain, and we won't bore you with that. But that's something that I want to really emphasize, is that poor pursuits, asymmetric tonic reflex all over the place. So I'm going to show you how to remediate all of these things here at the end. But I want to tell you that if your child is not reading well, this is something that you need to look at. All right, let's get some lights again. So, and then visual perceptual difficulties, particularly in symmetrical representation of figures. So this is when, have you ever seen those drawings like you have, like you'll have a bunny rabbit on this side, and then you have to trace the bunny rabbit on that side? Or you can draw a palm tree, really stellar and awesome to the right, but as you try to take your palm fronds to the left, it looks really stupid and ugly. You know what I mean? Or you draw a cloud, it looks really good to the right, but as you go to the left, it looks kind of like a pancake. That's what we're talking about. It's this asymmetric tonic neck reflex. Next is the rooting reflex. We talked a little bit about it. You know, I love autistic children. I do. Maybe because I'm mildly autistic. But I love these kids because the way that they sensory seek and just how honest they are with you and all of those things. But I'm not saying if you retain the rooting reflex that the child's going to be autistic, that's not what I'm saying. But what I'm saying is that the hypersensitivity around the mouth. I don't know if any of you have experience with autistic children, but they are sensory seeking little critters, and I love it. Because my niece, I mean, man, she has to have it around her mouth, to the point to where she cracks and bleeds, and it's kind of sad sometimes to see it, but they're really, really sensory seeking around the mouth. And they lack mature swallowing movements, speech and articulation become a problem, and poor manual dexterity. All because we're retaining the rooting reflex. Spinal Galant. This is our ADHD kids. So this is ants in the pants, also associated with bedwetting. It's amazing. You do one reflexogenic remediation, or AKA exercise, for an aberrant primitive reflex. It's amazing. People think that I'm so smart because I get parents that come in and they got a 14-year-old wet in their bed. It's embarrassing. They're still wearing pull-ups, this, that, and the other. We do a few dietary things. We do the remediation exercise for this. Bedwetting goes away. Easy as that. Poor concentration, poor short-term memory, hip rotation to the side when one's walking. And so with hip rotation, I'm not just talking about foot flare. You see the hip rotation. So that's not just this, that's that. And so that's something, as you watch your kids walk, look for that. And I'll show you what it looks like with a spinal galant response. Next, tonic labyrinthine reflex. These are your poor posture kiddos. So your labyrinth, that's just referring to your inner ear. The inner ear has 3 circular, semicircular canals that do a lot. They control the eyes, they control the head positioning, they control where you're at in space, they control a lot of stuff. A really cool book to read that will make you cry is called The Brain That Changes Itself by Norman Deutsch. And it's a great read because it talks about the plasticity of the brain. So he talks about traumatic brain injuries and the people that he's had the opportunity to work with and helping getting them functional again. There was a woman that took gentamicin for oddly enough, an inner ear infection. And what did it do? It completely wiped out her vestibular system. And so she was this woman that she completely lost all function in life. She quit being able to tend to her kids, do any of the housework, she lost her job, all of these terrible things happened. And because she didn't have her vestibular system anymore. And then the really smart guys at MIT were able to figure out through, man, I talked a lot, look at that, it's already 7:40. They were able to figure out through certain stimulations of the tongue to replace her vestibular system. And over time, they were able to remove this thing that they made for her mouth. Her tongue took over her vestibular system, and she was able to take care of her children again. The titubations in her head and all of this crazy activity that you're seeing from her, it all stopped. And all because they just trained the brain for another part to take over. And her tongue took over that. Her tongue doesn't have the semicircular fluid that's required for all of those really complex movements. Symmetrical tonic neck reflex. Now, this is the kids that have that simian walk. So the posture's like this, the head comes back like that, and then it's this walk like this. So that's a simian walk. And so they have poor hand-eye coordination. These are your messy eaters. I'm sure the guys on this side of the room probably have symmetrical tonic neck reflex consequences. I'm sure if I were to look at your plates after you eat, you got food all over the place. It's a child that can't readjust from looking at the blackboard to the desk. That is a huge processing thing. Notes, 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 more notes, 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 notes. If you have an underperforming vestibular system, then you have big consequences when it comes to learning. Difficulty learning to swim. Again, these are all big vestibular types of things. And that's it. So, next, we will move on. Oh, because I'm plugging books, Here is a really, really good book. You Are What You Eat. In Doctrine and Covenants, section 89, I'm sure all of you are familiar with it. Right? You Are What You Eat. So, here is the kid-friendly ADHD and Autism cookbook. It is a fantastic, I'm not even going to touch diet, all that stuff, unless people ask questions. It gets into the philosophy, it gets into why would I eat a gluten and casein-free diet. It talks about excitotoxicity, all of those things in layman's terms. But then, my philosophy is if you take something away from a child, you have to give them something. Because it's got to be a give-take relationship. That's the only way that I make progress. And so, this is a give-take relationship in this book. It's got all the recipes, everything that you can do. So if you're going to take refined sugar away, we've got to give them something sweet, because they still want to eat something sweet. You don't want to ostracize them from their class. You know, they don't want to be eating cardboard, tofu, and water. And so here are some really cool strategies and recipes when it comes to that very thing.
Can you pass that around?
Sure. So, now we will, so the things that I wanted to get across for the reflexes, the rooting reflex. It's responsible for reflexogenic feeding movements, and it's the foundation of mouth movement. Your palmar reflex, it's the grasp leading to independent thumb and finger movement. Spinal galant, it affects your posture, balance, and coordination. Symmetrical tonic neck reflex. If we can generate an email list, I can email you all of this stuff, and I think that would be pretty cool that you could have it, because I can give you like all of the different positions and how to effectively do these remediation exercises. Because if you're doing it wrong, it's not going to work. Symmetrical tonic neck reflex. Transition from lying on the floor to crawling head movement that is automatically linked to arm and leg movement. Asymmetric tonic neck, it's the start of head, eye, and limb coordination. And then your moral reflex is your startle reflex. Automatic response to sudden change in sensory stimuli. So let's get a volunteer, preferably a male. Perfect.
I love being made a fool of.
So, right there. So the rooting reflex, go ahead and close your eyes. I am going to touch your face.
I just put my gun down first.
Just don't bite my finger. Well, anyway, I don't have any. I have this little sensory stick that I use to test these reflexogenic mechanisms. Now, if the rooting reflex was really apparent, we'd give a sensory stimuli. He's going to turn his head like that to the top. Perfect. It's hepatitis free, I promise. So sensory stimuli is going to happen here to the left side. A really, really apparent reflex, he's going to turn like this. Now, something less apparent, something you say, well, that's not a reflex. You're going to see the angle of his mouth deviate towards the side of stimulation. So quit smiling for a second. So he has no rooting reflex, but he's probably thinking like the devil. I'm not going to do it. I'm not going to do it. And so we're going to the other side. Just stimulating this side. Doesn't have it. So things that we can do if your child does have the rooting reflex. That's exactly how you assess it. Things that you can do. Speech pathologists that have this bite stick. And we have several of those bite sticks, and they're pretty cool. What you can do is actually stroke the side of the face several times, several times, several times. It's just like working out. The more you do it, the less the cortex is going to become not there. It's going to become online and apparent, because that sensory information is going to feed the cortex. And so the cortex is going to start to inhibit that rooting reflex, okay? Now, once we start to inhibit the outward manifestation of the rooting reflex, now we need to go on the inside of the mouth. That's where you take that bite stick. It's a really thick tongue depressor, and then you have them bite down on one side, and then you pull forward. Pull forward, hold it for 10 seconds. Go to the other side, bite down, pull forward for 10 seconds. And what that's going to do is help strengthen all of those muscles in the inside of the mouth, and then neurologically start to inhibit where the rooting reflex comes from. So the next one, palmar reflex. Palms out like this. So you need something a little bit sharper when it comes to this. So the palmar reflex. It can be as dramatic as you put something in the palm and these kids, right there. So that's a really, really apparent reflex. You put something in the palm, reflexogenically, whack, they grab it. Now, some of your kids with a less apparent palmar reflex. You go to stroke the finger or you stroke the hand like this, just a really, really light sensory stimulus. And what you'll see is that the pinky will just ever so slightly start to approximate the palm. So you'll see something like that. Or you'll see a really, really small movement like that. That's not a big deal. What you want to start doing for that is you want to start approximating, doing exercises just like this. So you're approximating independent finger and thumb movement. Bump, 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 bump. And so you do these type of exercises. All these primitive reflex exercises that I'm talking about, I do these every morning and every night on myself. I have flaming ADHD on fire. I was one of those kids. Next, the spinal galant. What we're going to do, let me have you turn around the other way, straddle the chair. Actually, you know what, we'll get on our hands and knees just like this. So we'll get just like this. So this is how you assess it. So you got the kid on the hands and knees, the shirt's going to come up, I'll spare you that. And so what happens, same little sensory stick, you're just going to stroke the side here and stroke the side here. Now what you see on a child that's got the spinal galant reflex really apparent, they'll be like this, and the side that you stroke, or the flank of the back that you stroke, they're going to do that. And they're going to do this. Every time you stroke it, it's a reflex, they can't help it. And those are your ants in the pants kids. Those are the kids that always sit like this. They'll either sit like this, these are your ADHD kids that have that poor posture that look like they don't give a darn, and they're always sitting like that. Because subconsciously, they're not wanting to, you probably have it. So subconsciously, what they're doing is avoiding sensory stimulus to the flank of the back that's going to reflexogenically cause these movements like that. Or you have your kids that sit like this. So they sit on their feet, and they're always sitting on the edge of their chair. They have that simian position, these inward rolled shoulders like this, and the head tilted back like that. And then those are those kids. So that's that's how you recognize the spinal galant reflex. Now, you know what? Now we're just going to be on the floor. So we'll get on our hands and knees again. So we're like this. Now we're looking for the symmetric tonic neck reflex, okay? So what we're going to do is you're going to have them approximate their chin to their chest. There you go. And then you're going to have them bring the back of their head towards this way, just like that. There we go. Keep going, a little faster, a little faster, a little faster. Things that you're going to see when it comes to this. If it were a positive reflex, you probably got a pretty good cortex. I'm impressed. You're a lawyer, right? Yeah. Okay.
They worked it out.
So what you're going to see reflexogenically with these guys is that when they approximate their chin to their chest, you're going to see the elbow just buckle a little bit. And then whenever the head comes back to this direction, you're going to see the feet come up ever so slightly, just like that. And it's reflexogenically happening. And you're going to say, oh, you just raised up your feet. Then you know what your kid's going to do? They're going to think about it when they do it again, and it's not going to happen. So you don't tell them this stuff. Yeah. You just watch the movement. So that's the symmetric tonic neck reflex. Keep that position. Now the asymmetric tonic neck reflex. There's two ways that you can assess this. What we're going to do, we're going to be on our hands and knees just like that. Now what I'm going to have you do is we're just going to look to our right like this, and then we're going to look to our left like that. Now what we're just looking at is the relationship between the head and the arms. So when he looks this way, when he looks to the right, it's going to be the opposite arm is going to go. So he's going to be looking this direction, and that arm's going to go down. Going to look this direction, arm's going to go down. So that's the asymmetric tonic neck reflex. The other way you can stand up for me. We're going to put our arms out like this, and you're just going to have them look to the left, look to the right. So he doesn't have it. Look to the right, look to the left. That's because the arms have to be in the visual sight, because we're so visually driven. And so if we lose contact with our arms, then it becomes a sensory integration type of experience, and and those kids don't like it. Next is going to be the Moro reflex, and this one is a really hard one to get the kids to kind of display that to you. So what happens is you have them turn around like this, And I like to do it, I always do it at the end of my exam, because if I did it at the beginning of the exam, they wouldn't trust me for the rest of the thing. And so they'll be standing there, and then you just give it a big loud clap right behind their head. And that's going to rip. Now, you're not looking for the child that just turns around and looks at you. You're looking for the child that, you see that, just that really quick, hands go out and everything. Because take a neonate, brand new baby, just came out of the womb. So they're like this, the legs are up. You take that little one that's about to come out, and then you just take them and drop them like that. And what happens? Their arms come way out. And so that's the moral-startle reflex. So what happens when we retain those things is that you get an activation of the wrong part of your nervous system. The autonomic nervous system, it's not the wrong part. It's just you don't want that part of your nervous system to be dominant. Because the autonomic nervous system, you're married to a chiropractor, so I'm sure you hear a lot about this. So just bear with me. Is that the autonomic nervous system is going to activate things like your catecholamines, norepinephrine, epinephrine. All of that stuff is catabolic. In other words, it tears tissues down. So if you're in a constant sympathetic state, then you can imagine you're not building good stuff. You know, you're tearing proteins down. You're tearing down neurotransmitters. You're tearing down insulin. You're tearing down glucose. All of those things and making really, really noxious chemicals. So that's the moral reflex. Now what we're going to do is show you the remediation exercise for each one that we just talked about. So the rooting reflex. Well, I already told you about that. That's the bite stick, stroking the face several times. Now all of this stuff is built upon the concept, you can sit down now. All of this stuff, I'm kind of going fast now because I have like 5 minutes, is neuroplasticity. You know what I'm saying. Neuroplasticity. And so all that means is that the more times you fire that neuron, the more efficient it becomes and the less energy it has to take care of the same action. So for example, you can do functional MRI in some of these kids and you see different parts of the brain light up through different activities. Well, as you become more neuroplastic in an event, then it takes less of your brain matter to accomplish the same thing. And that's what we're after, neuroplasticity. So, when you rode a bike, you didn't learn how to ride a bike in 10 minutes. You learned how to ride a bike over the space of like 6 months. You took some face diggers, you were falling off to the side, you lost a lot of skin, and you really start to question. Well, that's neuroplasticity at its finest, because it's becoming more plastic in your brain, and you start to understand that. And so everything that we do, you have to do several times. You can't just do this exercise one time and be like, okay, all done. You know, no more ADHD, ha! You know, that's not the way it works. You have to be very disciplined in your exercise regimen. So, neuroplasticity, that's what that's about. So the palmar reflex, that's independent thumb and finger movement, right? And you're going to see these kids, I mean, it's all over the place. You just see it, it's really kind of funny sometimes to watch it. Now, the spinal galant, that's your ants in the pants, your kid, flank to the back, wiggling around all the time. So here's the remediation exercise. You ever done snow angels in the snow? It's that. But the same thing that we have to make sure that we're accomplishing here is that the low back is in contact with the ground. So if you have a child that will not put their low back to the ground, what you have to do, you mind laying on the ground for a second? What you have to do to warm them up for this exercise, go ahead and bend your knees. Okay, so I'm just going to take control of his knees like this, and then I'm just going to roll him back and forth to start to get that the back in contact with the ground. Just like this, rolling it back and forth, back and forth. So you might not even be able to get to the exercise for the first month. This is as far as you can get. So what you have to evaluate is that the low back is in contact with the ground. His low back is in contact with the ground, so he'd be ready for the exercise if he had this reflex. How about for we? So now what we're going to do, we're going to pair breathing with the inward and outward movements of the arms and legs. So I'm going to inhale diaphragmatically, and diaphragmatic breathing is different than the way that you guys breathe, because adults breathe with your secondary muscles of respiration. It's poor oxygenation. So diaphragmatic breathing, when I breathe in, my belly button is going this way. And so it's out and back in.